Thank you so much for inviting me today, and I'm really thrilled to have the opportunity to speak to you all today. I know that this is really designed as a chance for you guys to learn a lot about different areas of how bladder cancer is diagnosed and treated. And so knowing that the pathology piece of this is very important, and there was going to be a lot of discussion about muscle invasive and not muscle invasive and staging, I decided to take a slightly different tack today and actually spend a little bit more time talking about what pathology is, because I know it's a very big black box for a lot of people. You know that your tissue gets sent, and then you know you get a report. So I want to try to tell you a little bit about what happens in between those two steps. And then I'm going to spend a little bit of time talking about some of the specifics about bladder cancer, but I know that you're going to see that over and over again today. And then if I have time, I'm going to talk a little bit about what I consider to be the next wave in pathology, which is called personalized medicine or molecular diagnostics, which is my particular area of specialty. So I'm going to start off by a little bit of pathology myths and truths, because pathology, I think, is a fairly misunderstood specialty. So for starters, I think that there's lots of TV shows that prominently feature medical specialties like emergency medicine, surgeons, crazy internists like House. But there really aren't very many TV shows that talk about pathologists unless they happen to be a medical examiner. So when I talk to people about being a pathologist, everybody says, oh, you must be a medical examiner. But the reality is that the vast majority of pathologists have nothing to do with medical examiner on a day-to-day basis. We all learn to do some of that as part of our training, but pathology is very much an active specialty about patient care and integrating into patient care. So I will be very happy if I never again have to do anything related to medical examiner work, which actually seems like it might be possible. Another sort of myth about pathology is that it all happens after the fact. A lot of doctors like to joke with pathologists, oh, you give us the answer too late. But the reality is that we try very hard to make sure that pathology is a very active part of disease management. And I think especially in the world of oncology, all of the oncologists and oncologic surgeons will agree that pathology is a very active part of the patient care team and a part of management. And this is because a lot of treatment decisions are dependent on what the pathology report says. And so, for example, this big decision we were talking about earlier, muscle invasive versus non-muscle invasive, that's a decision that the pathologist arrives at from looking at the cells, from looking at the slides under the microscope. And so we are very much an active and integral part of the medical care team. You just don't happen to get to meet us very often. And then the third thing that I'll just tell you is that a lot of people, especially other doctors, talk about how pathologists like to describe everything in terms of food. And I will tell you that that is the myth, and the truth is that we just like to describe almost everything in terms of food. So there will be a couple of food analogies today just to sort of prove the point. So this is the dictionary definition of pathology. I looked this up on one of the online dictionaries, and I can sum this up as wah, 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 because that's about how much relevance it has to what I do on a day-to-day basis. You can read this, and this does not tell you anything about what a pathologist actually does. So the way I describe pathology when I talk to people is that anytime anything gets taken out of anybody, it gets looked at by a pathologist. And there are a few exceptions to this, but by and large, that's the truth of the matter. And the idea is that if your doctor thinks it's important enough to take off of you or out of you, it's important enough for somebody to look at it to know what it was in the first place. So what we do is, in large part, look at things that come out of people to describe and to classify what it is. So we look at it to classify the nature of the lesion. So I would say the vast majority of what we do from this perspective is deciding if something is cancer or not cancer. But there are other areas that we have to think about. Is it an infectious process? Is it an inflammatory process? So not everything is about cancer versus not cancer. And so when we look at slides, we have to sort of look at it from a very blank slate perspective. What are all the possible things that could cause somebody to have a lesion that makes a doctor want to take it out? We also want to try to classify the lesion into discrete groups. So if I've decided that it is a cancer, what type of cancer? Beyond what type of cancer, I can even subtype it beyond that. for something that I've decided is infectious, well, it's not very helpful for me to say to the doctor, yeah, this is infectious. It's a lot more helpful for me to say, this is infectious, and this is what I think the infection is. And then, as has already been discussed, a big part of what we do as related to cancer care is part of characterizing the aggressiveness and the extent of the lesion, which is grading and staging. So I'm going to sort of describe to you this black box part of pathology that I think a lot of people really don't have a chance to learn about. And first I'm going to do it in words, but I've got pictures coming right after this so you can see what I'm talking about. So first, of course, the specimen arrives to us. And right now I'm predominantly talking about things like biopsies and resections. And what happens is the specimen is evaluated what we call grossly. And this is where we take a look at the whole specimen and we describe it, because a lot of diagnosis starts just from the naked eye. What does it look like? How big is it? Does it look normal or abnormal? If it looks abnormal, what's the nature of that abnormality? What we do, especially for larger specimens at that point, is we cut it into smaller pieces. And the analogy I will give you for this is related to food. So the food analogy number one is that this is similar to cutting up a loaf of bread. And it is so similar to cutting up a loaf of bread that we actually call it bread loafing in the lab. And the analogy I'll give you here is if you say you have a loaf of bread and you've hidden 3 raisins in your loaf of bread, you're not going to be able to tell very well from the outside of that loaf of bread whether those 3 raisins are there and where they are. So what we do with tissue is we cut it into thin slices, just like you might cut a loaf of bread, looking for where those raisins are. And by cutting it into thin slices, we're able to identify not only whether the raisins are there, but where they are relative to everything else, and where they are relative to things like margins, which are very important for people to know about. Because if the raisin or the tumor happens to be right next to the margin, that's an important piece of information for the surgeon and the oncologist to know about. We also fix the tissue in formalin, or sometimes other fixatives, but usually formalin. And the other food analogy I'll give you is this is like pickling. So the idea is to put things in a spot where it fixes them in time, so that way when we go to look at them later, it looks just like it did when it came out. And if we don't do this, things are going to degenerate, they're going to fall apart. It's going to be very hard for us to look under the microscope and have any idea what we're looking at. So this is a part of standard process in pathology where we're basically pickling the tissue to be able to look at it a day later, a week later, a month later, 10 years later if we want to. After this, the specimen is processed. Now, processed is another black box. And what I can give you an analogy here is that there have been lots of exhibits around the world in the last decade of bodies in motion. There's the original bodies exhibit. This is all a form of plastinization. And processing in pathology is a very similar process, and the idea is that we dehydrate the tissue, we harden it, and then we rehydrate it. And the idea is to make it hard enough that we can cut it into thin little pieces to be able to look at it under the microscope. The specimen is then put into a block of wax, which is usually a paraffin wax. And many of you might have heard about your block, or the pathology block, and this is what we're referring to. This is where the piece of tissue actually lands in a mold of wax, and that's what allows it to be held in place to allow those very thin slices to happen. So then the paraffin block is sliced very thinly, and those slices are put onto glass slides. I think this is my last food analogy, so this is like a deli slicer, but on a very small scale. The glass slides are then stained up with standard stains, and having the stains be standard allows me to look at cases and be able to compare one case to another and to be able to know what normal looks like. So the fact that we handle these all the same way allows me to know how things should look, and then when I look at something that is abnormal, I have a basis of comparison. And then after that is the microscopic evaluation, and that's really where the pathologist starts. And so a question I get a lot is, well, why does it take a week for me to get my pathology back? Why did my pathology take 2 weeks to come back? This is a long process, and just the processing part of this can take anywhere from 24 to 72 hours. And after that, that's where my job actually starts. So the first part of this doesn't even happen for sometimes 2 days. These are the pictures just to show you in reality what this looks like. So after a specimen has been bread loafed, we take the pieces that look abnormal and we put them into these things called cassettes here. And the cassettes are designed to allow all of those chemicals that process the tissue to permeate the tissue so it can get adequately treated with all those chemical steps. Here you see a tray of cassettes. It's going into a processor. So this is the processing, and luckily for us, this is all very automated now. We put it into this machine, we hit a few buttons, and 12 hours later, we get our processed tissue out. After this is where we put the tissue into the paraffin wax. So on the top there is a station that has a hot wax dispenser. It has a hot side and a cold side, and what we do is we take the tissue out of that cassette. It's now hardened. We put it into a mold, and we take the hot wax and we pour it over the mold, and then we move it over to the cold side so it'll cool off and that wax will harden. And what you see below that is the net result of that, a piece of tissue in a block of paraffin, and that is what we use to cut later. This is the deli slicer, and I did my best to get some live action shots here. So this is how we actually make the slides. And then we stain the slides using these standard stains I described. The slides get finished up, and after that is when I can look at it under a microscope. So as has been discussed already, and I think will be discussed several times today, much of cancer care and much of cancer diagnosis is dependent on the pathology evaluation, which determines cancer type and cancer grade and cancer stage. And so the cancer type and grade can frequently be determined on a minimally invasive technique, so such as the bladder biopsies or voided urines or bladder washings that have been described. Cancer stage, on the other hand, which is dealing with the extent of disease, first of all, I do want to tell you it's defined differently in every organ system. So we're talking about muscle invasive and extensive invasive in bladder cancer today, but there are big books that tell me how to do this for every different organ system. So it's different in every system. So how I decide what stage a lung cancer is very different from how I decide what stage a colon cancer is very different from a bladder cancer. And it's important to realize this because how those things are decided is really a very rigorous scientific process. And every few years, people get together and they look at all of the new evidence that talks about what the outcome is for people for very specific criteria. And that's how stages are defined, is they say, well, we know that if in bladder cancer the muscle is invaded, that has a higher recurrence rate, it has these other features associated with it, so we're going to call that a higher grade. And so the fact that we are continually accumulating the data that allows us to always refine those definitions is part of the ongoing advances in cancer care. And it's different in every organ system. So as has been discussed, staging can be approximated using imaging techniques. That's the clinical standard because the goal isn't to go in and take whole organs out on everybody, but for the purpose of doing those clinical definitions to really define how the cancer care moves forward, the pathology stage is considered the gold standard. There's going to be more discussion today about the different types of bladder cancer. As has already been discussed, the vast majority of bladder cancer is transitional cell carcinoma, but you can also have bladder cancer that comes in the form of squamous cell carcinoma, adenocarcinoma. I didn't mention the non-imaginatively named small cell carcinoma, which is an entity but is also quite uncommon. And in terms of how pathologists evaluate bladder cancer, there are lots of different specimen types that can come to my lab to say, is this or is this not cancer? We've talked about voided urine, bladder washing, and bladder biopsies. Those are used for both diagnosis, but also, very importantly, they're used for surveillance. And I think that that's a very important piece to remember, is that part of the spectrum of specimens that can come to pathology for evaluation has to think both about making the initial diagnosis, but also about the follow-up care. There are also other specimen types we see quite regularly. There's a transurethral resection of bladder cancer, and then cystectomy specimens as part of therapy. We also look at those. So in terms of bladder cancer diagnosis, this has been discussed briefly. When we look at voided urine, we're looking for cells that have been shed into the urine. But what's important to recognize here is that urine is a fairly toxic substance for your body. It makes sense. Your body's getting rid of it. It doesn't want it. So it's something that is very unfriendly to cells. Cells don't like to live in urine. So when we look at voided urines, those are actually really hard specimens to look at because just the very nature of what the cells are living in makes the cells sort of degenerate and fall apart. And so when a diagnosis is made on a voided urine, you're looking at your starting point is cells that already don't look quite normal. Bladder washings, as I'm sure most of this audience knows, are part of a procedure, and those tend to be a little bit healthier looking cells. It makes it a little bit easier for us to make that initial diagnosis and as well as follow-up care. And then bladder biopsies are a little bit different from those two other specimen types because in a biopsy they're actually taking a piece of the tissue, and that allows us to look at the cells as they relate to one another, not just cells floating free. And being able to look at cells as they relate to one another is a very important and useful part of a pathology evaluation. There are lots and lots of different subtypes of bladder cancer. And there are a couple that are more common, but because there are so many different subtypes, I didn't really want to spend time going into it because it becomes such an individualized piece of it. I could spend a whole hour talking about just that. So recognize that there are lots and lots of different subtypes and that some of them are less aggressive than others, and that's part of how we grade the tumor, is some subtypes are by definition more aggressive than other subtypes. And then we've talked a little bit about grading, and I know that there's going to be more about this today as well. This is usually done at diagnosis, but then it's redone at every part of pathology evaluation, and it classifies the lesion as either high grade or low grade. There used to be that we had multiple systems for this. People would call them over 3 grades. Some people call them over 2 grades. But more and more, I think it's become universally adopted that people use a 2-grade system for this low grade or high grade. So this is another version of some images you've already seen today, which discusses how the anatomy of the bladder plays into how we stage. So as has been mentioned, the bladder is a very muscular organ, which makes sense. You need to be able to exercise those muscles when you want to void your urine, and you need to be able to not exercise those muscles when you don't want to. So these are muscles that have to operate in a concentric way to take a round, spherical type structure and close it down. And that constitutes the largest mass of the bladder. But in terms of where most cancer comes from, as has been discussed, it mostly comes from what we call the mucosa or the epithelium. And those are the lining cells of the bladder, and the vast majority of bladder cancer derives from those cells. And so in order to stage the cancer, for most cancer types, what we do is we look at that lining and we find where the cancer started in that lining, and then we follow it downward into the muscle to see how far into the muscle it goes, if it goes into the muscle at all. And over on the right is a figure that's very similar to what you've seen, which is describing how we relate the depth of that invasion to that stage that has been defined by the clinical outcomes. So in terms of specimen types that we might see that relate to staging, transurethral resection of bladder tumor is a specimen type that we see that has both diagnostic and therapeutic implications. But this is a specimen type we very frequently use to try to assess the depth of muscle invasion. It's important for me to convey to you, though, that because this procedure is done through a scope, it comes out to us in little pieces. So it's lots and lots of little pieces that were taken out through that scope. And that makes it a little bit hard to assess the full extent of invasion. We can see on any one little piece of tissue where the tumor is on that piece, but we can't really reconstruct it into a whole organ to look at it from one end to from the inside all the way to the outside. So there's a distinction between that and what I'm going to talk about next. But for tumors without muscle invasion, this may be from a surgical procedure perspective where things stop. But for tumors that do have muscle invasion, frequently more surgical treatment is needed. That's not always the case. So muscle invasive lesions that do go on to have a cystectomy, this is the counterpoint, is that when we have a cystectomy specimen that comes out to us, that comes out intact, where we can see all the way from the inside to the outside, and we can evaluate the full thickness of the bladder, and that can give us a very, very precise ability to tell how deep the tumor goes. I did want to spend a couple minutes talking about pathology reports, because I know pathology reports can be very confusing to people. I actually get a lot of calls from people asking me to explain their pathology reports. Every institution has a slightly different format. They might have slightly different section headings, but for the most part, pathology reports are clumped into different sections. The most important section, obviously, the one that's usually at the top of the page, is the diagnosis. And it's usually in pathology ease in terms of what the diagnosis is, but this is the section that really conveys what the pathologist thinks is the bottom line of what is on the slides. Comment and microscopic description are sometimes used interchangeably, and this is where the pathologist gets to sort of add additional thoughts or findings. And for some lesions that are really challenging, for something where, say, for example, I have a lesion and I'm weighing between two possible options, and I show it to 5 of my pathology colleagues, and between the 5 of us we have 3 different answers, and none of us is really 100% sure what something actually is. That might go into the comment section. You know, we favor this to represent X. And this is our way of being able to say, there are shades of gray here, and this is actually the part of the pathology report that really allows the pathologist to communicate the shades of gray. The gross description is where we actually describe what we did at that initial step, that grossing step, where we looked at the specimen and it describes what we saw before it went in for processing. This is a little bit of a cheat sheet for you in terms of some of the terms, the pathology ease that shows up on pathology reports. Carcinoma is the medical term for cancer. It defines a specific type of cancer, but that's the bottom line. You might see the word dysplasia on a pathology report. That indicates pre-cancer. Muscularis is the term that we use for muscle. And depending on the pathologist, most pathologists will describe the full depth of invasion as being the perivesical adipose tissue, so that means that it goes to the deepest layer. And then I've listed WHO and ISUP. Those are the 2 major classification groups that people have used in the past. And the 2-tier group, the low grade, high grade, is the ISUP classification. You guys did just hear about T, N, and M staging. And lastly, you might read in a comment section about something called immunohistochemistry. That is a special staining procedure that pathologists can use to help us classify lesions. So when we have a lesion that could be one of 2 different things, sometimes doing these special tests help us define whether it's option A or option B. So with a couple of minutes left, I'm going to just tell you really briefly about what I consider to be the next wave of pathology. So pathology has been very close to the same for nearly 100 years. And it involves taking tissue, cutting it up, processing it, and looking at it under a microscope. And there have been a few big changes in that time frame. So we have a lot of automation, that helps. Optics have gotten a lot better. And we have these special stains I just described. But aside from that, it's more or less been the same field. In the last 10 or so years, there's been this development called molecular pathology, which plays into personalized medicine. And that is actually what I specialize in. And the idea behind molecular diagnostics is the ability to look at individual subsections of tumors to help try to refine diagnosis, predict the disease course, and predict response to therapy. So how molecular pathology works is we actually take the slide and we actually dissect out, we pick out the individual tumor cells so we can look at the genes in those individual tumor cells. We also sometimes look at those individual tumor cells on the glass slide, and that's using FISH, which was mentioned, and I'll show you some of that. So personalized medicine is reality today in many areas of medicine, in lung cancer, in melanoma, in colon cancer, there are genetic tests I do on tumor cells every day that tell the oncologist what therapy to use. So, of course, the question today is how does this play into bladder cancer? So one area that this plays into bladder cancer is this specialized FISH test called UroVysion. And UroVision helps to look at some of these cells I told you look very degenerated and can be hard to look at in a urine specimen. So in a urine specimen, when you have a really degenerated cell, sometimes it's hard to know if it's just a degenerated cell or if it's a cancer cell. And by doing these genetic tests on those cells, we can help elucidate whether we think it is actually a cancer cell. And this is based on actually looking at the amount of specific markers of DNA. And on the left, you have a case that is not tumor with a limited number of dots in each cell. And on the right, it's a tumor specimen that has a lot more dots in each cell. And this is how we look at these cases to help us decide that something is a tumor. There have been a couple of genes that have been described in bladder cancer that have been known for actually a long time, are very common. So a mutation in a gene called P53 is very common in bladder cancer, and it's very commonly seen in aggressive bladder cancer. Conversely, a mutation in a gene called FGFR3 is very common, and it's very commonly associated with non-aggressive lesions. And that's great information to know, but it doesn't tell me anything I can't already tell by looking at the slide. So the question is, what can we do to give us information that actually helps define what treatment to use? And Dr. Thedrescu, who's going to be talking later today, who's the director of the University of Colorado Cancer Center, is actually working on developing a test that does exactly that. And I won't try to explain this because it's something I'm really just learning myself how to understand. But the bottom line is that you can use genetic tests to help decide very early in the diagnosis of disease. At the point in time when you have a biopsy, you can do these specialized tests to say, well, all we have right now is a biopsy, but based on this test, this cancer is very highly likely to go to the lymph node, or this cancer is very highly unlikely to go to the lymph node. And actually, we are working on trying to advance this exact testing method to bring it to clinical trials and see how well it can work in reality. So from an advocacy perspective, what I will tell you is that research dollars that are very limited, as you have seen in bladder cancer, support discoveries in bladder cancer biology and treatment. But in terms of actually being able to have tests that are used to make a change in how we manage patient care, we also need research dollars to help develop those tests. And developing the science behind the test is one thing, but turning it into an actual clinical test where I can run it every day in the exact same way and know exactly what it means is actually a different science and also needs research support. Thank you very, very much for having me here today.